Today is World AIDS Day. On this AIDS Day, I would like to discuss upon one important topic that is coming up in HIV medicine, that is pre-exposure prophylaxis. Pre-exposure prophylaxis refers to the use of antiretroviral drugs to prevent HIV infections before the exposure has happened. Now, this has been in use in the Western countries for a long time, but it has not been much popular in India. But this is a method which can significantly decrease HIV infections and help us in moving towards our goal of HIV elimination. Now, what is HIV pre-exposure prophylaxis, or what is called as PrEP? As I already told, it is the use of antiretroviral medicines to prevent HIV infections, and these are taken before the exposure happens. So, who are those who are eligible for PrEP or pre-exposure prophylaxis? These are patients or persons at high risk for contracting HIV. These include partners of HIV positive patients who have a positive or a detectable viral load. That is one group. The second group is those who are MSM, transgender, or heterosexual people who have a high risk of contracting HIV. That is, they practice condom-less sex, or they have contracted a bacterial sexually transmitted disease. And there are people who are injection drug abusers. So among all these, there is a risk of HIV transmission, and PrEP is indicated in these group of individuals in addition to other protective measures like condom use. What are the regimens that are available for pre-exposure prophylaxis? The most studied regimen is tenofovir disoproxil fumarate, that is TDF, with emtricitabine. This combination has been studied in various groups, and the experience with this particular regimen is the maximum. It can be used as a daily regimen. Also, there are evidences for an event-driven approach in this particular case. The only problem with this particular combination is that because of TDF, there is an increased risk of kidney impairment as well as bone loss. The second regimen that is commonly used is the tenofovir alafenamide emtricitabine, that is TAF emtricitabine regimen. This particular regimen is to be used as a continuous, that is a daily regimen only, because we don't have evidence much for the event-driven approach. Also, this is not preferred in patients in whom the risk is particularly through vaginal intercourse. The advantage of the TAF emtricitabine regimen is that there is less risk of renal toxicity as well as bone toxicity. The upcoming regimen is the long-acting cabotegravir regimen, which can be given as an intramuscular injection every 2 months. So the adherence of this particular regimen is very high because the persons have to get injections every 2 months. The only problem is that if these patients develop HIV while on PrEP, there is a risk of integrase inhibitor resistance, and as a result of which the treatment of HIV in these patients can be complicated. As I told you, the TDF emtricitabine regimen can be used as a continuous daily regimen where the patients take the medicine as long as there is a risk of infection. It is said that for those who start on PrEP, for males, they should wait at least for 7 days before the effect of the drug or the concentration of the drug is achieved, before adequate concentration of the drug is achieved. And in females, they should wait for 21 days. And during this period, they are advised to use condoms particularly. The second approach is an event-driven approach for pre-exposure prophylaxis. This approach is approved in MSM population, and only the TDF emtricitabine regimen is approved for this particular schedule. So here they follow what is called as a 2-1-1 approach. The person will have to take 2 tablets of TDF emtricitabine 2 to 24 hours prior to the anticipated sexual intercourse, and 24 hours after the first dose they will have to take the second dose, and 24 hours after the third dose, and as long as the patient has a risk, they should continue. The patient also should continue PrEP for 2 more days after the last exposure. So this is event-driven PrEP. Now there are a lot of things that has to be monitored at baseline as well as during PrEP. This is beyond the scope of this particular discussion. But one thing that I want to stress is that Even during use of PrEP, one should encourage the persons to use condoms, because that will, one, decrease the incidence of other sexually transmitted diseases, and also remember that PrEP is not 100% safe. There is a small risk of infection even on PrEP. So condom use should be encouraged in this group of patients.